Good morning, guys. I think we need to start. I was waiting just for a few minutes to allow others to join in, but I think we need to start for the sake of time. So this is a continuation of the urinary tract system abnormalities. What I've done is, because I know I will be able to finish the urinary tract system in probably 20 to 30 minutes, I've just added the amniotic fluid abnormalities so that we know that this is done. You will see that we are not starting with the very basic. One of the reasons why we are not doing that is because we have already done the basic courses several times. So, and these basic courses are available on our YouTube channel. So if you have any questions concerning the basic courses, you are more than welcome to go to our YouTube channel and watch where we talk about basic things like amniotic fluid assessment and so forth. So I think I was on autosomal recessive polycystic kidney disease, and I covered it in part. This is what I'll be dealing with today. Moving forward, I'll start here at the autosomal recessive polycystic kidneys. Let me put my film slide here. So slide share is coming. So it is as common as 1 in 30,000. Not very common in fetal medicine terms. But what you have to know is that the disease is a wide spectrum, which may include the renal involvement, liver involvement, and it can be divided into perinatal, neonatal, infant, and juvenile types on the basis of the age of onset or of clinical presentation. So that what it means is that babies who have, as you are scanning, you are going to see these babies who have borderline kidneys. Borderline means the kidneys are they look echogenic and slightly big, but they are neither there nor there. The advice you can give to those to the mothers of those babies that the babies should just have a follow-up of their kidney function with the pediatrician throughout until adolescence. Because sometimes you may reassure the parent that everything is fine, and for sure everything will be fine with these babies at birth. The renal function will be okay, and people may take this as a false alarm, but these babies may turn on to have recessive polycystic, autosomal recessive polycystic kidney disease later. So how do we identify them? On ultrasound, when you try to get the kidneys using the coronal plane, the coronal plane is where we look from the back. When we look coming from the back using ultrasound, we are going to see two large kidneys with a very small renal apophysis in the center. So these will be two large kidneys with a very small renal apophysis in the center. They are homogeneously echogenic, these kidneys, and the diagnosis is normally picked up at 24 weeks. So that means for women who come at 20 weeks for normal scan, it is possible to miss these kidneys. Hence, when you are not happy with the kidneys and you suspect that the kidneys may look slightly abnormal than they should look, you should try and bring back the woman for further assessment. Do not hesitate to bring the woman for further assessment. It's very important. Then the renal apophysis cannot be visualized because it will be just close, and there is gradual onset of oligar of the second trimester. This is what leads to the diagnosis in most cases, Oligar, where you check and the woman is not ruptured the membrane, but you look at the kidneys, they look big and echogenic. The incidence of chromosome abnormality and genetic syndrome is not increased. However, cystic fibrosis of the liver can also coexist in this situation, and we may end up with hepatic fibrosis. Again, what should you do? Detailed ultrasound examination to rule out the associated defects. Genetic testing should be done because the disease or the abnormality is caused by polycystic kidney HD1 gene, which is on chromosome, some of chromosome 6, region 2.1. So whenever these genetic testing are done, they need to be specific to the lab so that they do or they use the correct panels for checking for this mutation. Otherwise, we just say chromosome abnormality to come back as normal. In families at risk, there is room for prenatal diagnosis, including PGT, pre-implantation genetic testing. So the follow-up is ultrasound scan every 4 weeks to monitor growth and assess amniotic fluid. And the delivery again is within a hospital with intensive care. If you know that your hospital doesn't have intensive care, in utero transfer is better. Delivery timing around 38 weeks. Induction of labor is acceptable in this situation if there are no obstetric contraindications. The prenatal type, unfortunately, is lethal, either in utero or in the neonatal period due to pulmonary hypoplasm. So these babies may present with a very early second trimester Oligar abdominals. The infant and juvenile types result in chronic renal failure later on, and also hepatic fibrosis and portal hypertension. And they survive up to their teens, and they require renal transplant if they are to live longer. Babies with autosomal recessive kidneys, the polycystic kidneys. Then the recurrence risk is about 25% because of the Mendelian inheritance, which is autosomal recessive. Remember, any condition that is labeled as autosomal recessive, the inheritance pattern is about 25%. The recurrence pattern, the recurrence risk is about 25%. So always remember this. It's very important. Renal agenesis, when it is unilateral, it is as common as 1 in 2,000, but when it is bilateral, it is 1 in 5,000. The unilateral is often missed. The reason why it is missed is because people don't check kidneys properly according to protocol. So always have a tendency of checking the kidneys the way we described how the kidneys should be checked in our basic anatomy, the common fetal defects lecture, which is on our YouTube channel. When it is unilateral, you will not see the kidney. Like in this case, you can see this is the region of the kidney, but there is no kidney here. The renal fossa is empty. The verticalization of the adrenal gland is not quite clear here, but this was a case of unilateral renal agenesis. The color Doppler may help to demonstrate a single renal artery. Again, this is a coronary plane image. Then the contralateral kidney needs to be checked. If it is normal, sometimes it may have compensatory hypertrophy. So you may see that the contralateral kidney looks enlarged. Then in cases of bilateral, there is non-visualization of the kidneys and bladder in combination with the abdominals starting after 17 weeks. So these cases are rarely missed because as long as they go for a scan, everyone will notice that there is no fluid if they have a second trimester scan. Of course, further confirmation will involve color Doppler, and also the adrenal glands, they will be verticalized or they will have a discoid shape and move laterally and inferiorly. That's the verticalization of the adrenal gland. By that, we mean they'll be arranged parallel to the spine. That's what you can see very probably a shadow of it here. It's not coming out nicely to convince you, but This was a case where the renal fossa was empty. Then we have this, because of lack of fluid, as you are now aware, that amniotic fluid is required for lung development, for lung expansion. So babies who lack amniotic fluid are going to have small lungs. And as a result, they will have a small chest, and the heart will always appear large. They will have cardiac hypertrophy. This, I think, for some of you have seen it in women who have anadromness, that the chest looks small for the heart. If the pregnancy is continued, we may end up with talipes due to compression effects. So we may end up with talipes. A talipes is clubfoot. Then, what are the associated abnormalities? In the majority of cases, renal agenesis is sporadic and an isolated abnormality. The chromosomal defects, mainly trisomy 18, are found in about 1 to 2% of the cases. This information is very important in a couple who are inquisitive, who want to know more, who want to know whether this can be can recur and whether it's part of a syndrome. Because in about 10% of the cases, there could be an association of syndromes, such as Fraser syndrome. Fraser syndrome is an autosomal recessive condition characterized by renal agenesis, laryngeal atresia. Laryngeal atresia is difficult to pick in utero. Cryptothymus is again difficult to pick, but syndactyly is can be picked. But in this case, if there's fluid, it's tricky to check the fingers. Syndactyly is when the fingers are fused. That's syndactyly, where we have fused fingers or webbed fingers. So that's syndactyly. It may also be an association of the VACTRA association. I think last week we were talking about VACTRA. We were saying these are vertebral and ventricular septal defects, and we also have anatresia, tracheoesophageal fistulas, renal anomalies, the radial dysplasia, and single umbilical artery. So again, a syndromic pattern approach, like we described the other time, is needed for you to suspect these syndromes. Then mucus syndrome can also be associated with renal agenesis. This is sporadic and is associated with hypoplastic or biconate uterus. And also there is renal agenesis or dysplasia and vertebral rib anomalies. That's the mucus syndrome. Then the detailed ultrasound scan examination is needed whenever there is anadromnus or renal agenesis. Like I've always said, that you just note that there are no kidneys and you walk away. No, the baby still have to be checked as much as possible. When necessary, amnioinfusion may have to be done to try and elicit all the anatomical structures. Some may wonder and say, why do you have to go to this length instead of probably allowing the baby to be born and to be checked? There are certain abnormalities which are easier to check in utero, because whenever these babies are delivered, most of they are terminated phase, there is a lot of tissue distortion, and you won't yield much from gross anatomical evaluation when the baby is demised. So ultrasound examination may elicit certain information we may find difficult to elicit in the uterus, outside the uterus, due to rapid tissue deterioration. So karyotyping is offered when there are associated abnormalities. In isolated cases, karyotype is not routine. Then the follow-up should be standard, and delivery, standard obstetric care and delivery. However, when it is bilateral, it is lethal. Both in it is lethal in the neonatal period, and offering termination of pregnancy is a viable option in cases where it is bilateral. But when it is unilateral, Unilateral cases, when they are isolated, there's a normal prognosis. Humans do not need 2 kidneys. They need 1 to be alive. And the 1 normally will do the function as long as it is operating normally. So those with the unilateral renal agenesis will reassure them that the baby has a minor abnormality, but the baby will be fine. In some patients, there may be viscoureteric reflux of the other kidney. These are the cases where probably some intervention will be required after birth. Then after delivery, for girls, a pelvic ultrasound scan should be done to look for Mullerian structure abnormalities. The kidneys, the urinary system, in the genital tract system, upper genital tract system, they all originate from the same, they have the same embryological origin. So a defect in one part, it may likely affect the other part. So we should rule out things like Meyer-Rokitansky or Mullerian agenesis, where there is no uterus, or double uterus, conate uterus. All those abnormalities are possible in babies with renal agenesis. The opposite is true. So for gynecologists or doctors, even midwives, if you see a baby who has some genital abnormalities, Mullerian abnormalities, do not forget to check the kidneys as well. The recurrence, this is non-syndromic in 3%. When it is non-syndromic, the recurrence risk is 3%. And it is 15% when the parents have a unilateral renal agenesis, and then UPJ, urethral pelvic junction obstruction, as common as 1 in 2000, which is very common in fetal medicine terms, and it is more common in males. How do you identify it? Normally, you see the pelvic calcium dilatation without urethral dilatation. So these are the cases where the pelvis is dilated and this calcium callus is dilated as well, and there is no hydroureter. So these are the cases where you highly suspect the presence of urethral pelvic junction obstruction. The degree of pelvic calcium dilation is variable, and occasionally perinephric urinomas, which is encapsulated collection of urine due to a tear in the renal pelvis or callus of the ureter, and the urinary ascites may be present. So always be aware of perinephric urinomas. They collect outside the kidney, within the kidney capsule, because you know the kidney capsule is very tough. So yeah, and you may have urinary ascites as well, where there is base of the urinary tract. They are unilateral in about 80% of the cases, but in about 20, they could be bilateral. The incidence of chromosomal abnormalities and genetic syndrome is not increased. Then abnormalities of the contralateral kidney, which could be multicystic or ectopic kidney, or we could have renal agenesis. So always remember, if you see an abnormality in one kidney, look at the other kidney carefully to make sure the other kidney is okay. Again, investigations you have to do, just detailed ultrasound scan examination to rule out associated defects. Then every 4 weeks, ultrasound scan to assess the evolution of the condition and also assess amniotic fluid. Standard obstetric care is required here. The prognosis in the majority of infants, if the other kidney is okay, again, the prognosis is good. But if they are both affected, then of course the renal function has to be assessed after birth. If it is a severe kind of where there is damage of the cortex, then in those cases there could be issues of renal failure. But most cases which are mild to moderate, they have a good prognosis, a good renal function. Some surgery may be required after birth, such as pyeloplasty, may be required to open the UPJ junction or obstruction. In most cases, the obstruction is not complete, it's actually sort of partial or functional, so which is a good thing. So the blood will be visualized even in bilateral cases. But if you don't visualize the blood, of course, it's not a good thing. In those cases where there is complete obstruction, the kidneys end up being multicystic or polycystic kind of appearance. The recurrent risk is not increased. Urethral obstruction. Urethral obstruction, probably we can also call this LUTO, lower urinary tract obstruction, or we can call it BOO, as some call it, bladder outflow obstruction. It is common as 1,500 in males, but it can also happen in females. It can be caused by either urethral agenesis or agenesis or atresia, or persistence of the cloaca, or urethral stricture, or posterior urethral valves. So remember these causes. Sometimes don't think that it is always posterior urethral valve that may cause urethral obstruction. With posterior urethral valves, there is usually incomplete or intermittent obstruction of the urethra, which will result in an enlarged and hypertrophied bladder with varying degrees of hydroureter or hydronephrosis, and a spectrum of renal dysplasia. So you will see what you mean by renal dysplasia. I think yesterday with the case at Sally, renal dysplasia, you normally see that the kidney become echogenic with peripherally placed cysts. The cysts will mimic those of polycystic ovaries. Those who know polycystic ovaries, I think the case at Sally was classical of this. So you see this cyst, what we call dysplastic cystic degeneration. So there is renal dysplasia, which may be associated with posterior urethral, with the lower urinary tract obstruction. In cases where the obstruction is tight, there is going to be oligodermness and pulmonary hypoplasm. But some cases of posterior urethral valve, because the obstruction is not complete, the baby will have enough fluid to develop its lungs and be okay in terms of the lungs. There may be associated urinary ascites from rash of the bladder. Yes, the bladder may rupture. How do you know that the bladder wall is thick? When it measures more than 4 millimeters, then you know that the bladder wall is abnormally thick. So how do we suspect it? You see reduced amount of amniotic fluid after 17 weeks of pregnancy. If the obstruction is tight, in the first trimester, the condition may present as a megacystis. This is why when we are doing the CRL, it is important to always look at the bladder and measure the longitudinal length of the bladder, which should not exceed 7 millimeters. If the bladder exceeds 7 millimeters, it is important to follow up these patients. However, we know that 90% of the cases, if it is between 7 to 15, it is self-resolves. But if it is greater than 15 millimeters, in that case, it's more likely that there's an obstructive uropathy. And these babies will need to be brought early at 16 weeks for detailed examination and pregnancy counseling, in pregnancy management and counseling. So remember this. So try to measure the bladder length at the 11 to 13 week scan to see what the length of the bladder is. If it is more than 7 millimeters, then the baby should be flagged. Chromosomal defects, they are found in about 10% of the cases, so there's still room to offer them karyotype. However, other defects have to be ruled out, like cardiac and GIT defects have to be ruled out, which occur about 40% of the cases. Investigation, detailed examination of the baby is required, and amniocentesis for karyotyping analysis of cell-free DNA is offered. fetal therapy, decompression of the urinary tract has been achieved by ultrasound scan guided insertion of suprapubic vesical amniotic catheters and cystoscopic ablation of the urethral valves. For sure, it is feasible to do this therapy, but the benefits are so condensable. There's a trial called Luto that had to be discontinued. I don't think, it had to be discontinued. But there were some benefits in terms of the kidney, in terms of the lungs for certain babies, but there was no improvement in terms of the kidneys. So whether this intervention will improve both the renal and the pulmonary function is still questionable. So probably in the short-term future, I'll be offering this kind of procedures. So this is the kind of counseling that the expecting parents have to be given, so that they are aware that the procedure is not going to be a total panacea to the problems that they will be faced with. That's the information for counseling. So if pregnancy is continued, every 4 weeks, scan will be done. Then antenatal evaluation of renal functions relies on ultrasonography findings and also analysis of fetal urine obtained by urodocostasis. To be honest, this is not done in practice to try and obtain to do urodocostasis is not being done. But however, on ultrasound, there are certain poor prognostic markers that we normally use to try and counsel the couple. The presence of the bilateral multiple cysts or multicystic degeneration of the kidney. I think we saw one patient this week at Pari, but the good thing, it was unilateral. Bilateral multicystic degeneration of the kidneys, or a severe hydronephrotic with echogenic or cystic cortex, like the one we saw at Saleh. So that on its own is a poor prognostic marker, which we normally use to counsel patients. And of course, if there is anhydramnios again, because of the issue of the lungs, the issue of pulmonary hypoplasm, always remember that between 16 to 24 to 26 weeks, there is a stage of lung development we call canalicular stage. That stage has to happen with fluid present. But if there is no fluid, that stage is compromised and the baby will have plastic lungs, will not be able to breathe properly. So that is the basis of our counseling for patients who have anhydramnios. Then urinary sodium and calcium and beta microglobin with those values is also a basis of counseling if people manage to aspirate fluid and test it, urine in the baby and test it. But like I told you, that this kind of invasive is not routinely done really in clinical practice. But of course, for more inquisitive couples, sometimes people may have to do this. Delivery, hospital with intensive care and pediatric surgery. So if you are nursing these babies in a hospital where there is no intensive care or pediatric surgery, please transfer them neutral for the benefit of the baby. Delivery timing, 38 weeks. Induction of labor, aiming for delivery is the preferred choice if there are no obstetric indications. Then prognosis. There is high perinatal mortality due to pulmonary hypoplasia secondary to severe oligodamnios. Even those that survive, about 30% develop renal failure necessitating dialysis or transplant before the age of 5 years. So it is bad when there is severe obstruction. There is no increased recurrence, but if it is part of trisomies, the recurrence risk is about 1%. Then we have urethral vesical junction obstruction. It is, did I cover urethral? Okay, probably I didn't. It is as common as 1 in 10,000. Normally, is the presence of hydroureter and hydronephrosis with a normal bladder. The dilated ureter is tortuous and appears as a collection of cysts of variable size localized between dilated renal apophysis and the bladder. The etiology is diverse, including urethral stricture, ureteric stricture, or atresia, vascular obstruction, diverticulum, or urethral. Urethral cells are visible as thin-walled and fluid-filled small circular areas inside the bladder. They are usually found in association with duplex kidney and collecting systems. The upper pole carotidially obstructs, and the lower pole, or the lower one, refluxes. So, what we mean by urethral vesical junction obstruction, we are saying the obstruction is at the level where the ureter enters the bladder. That's where the obstruction is. This is the basis of why we are able to say this is a UPJ, uretropelvic junction. This one is a uretrovesical junction, because in UPJ, uretropelvic junction, you are not going to see the hydroureter. While in the uretrovesical junction, you are going to see the hydroureter, and the bladder will look normal. But you could have cases of BO or bladder outflow obstruction or luto, whereby you have a hydroureter and also a hydronephrosis. So be careful and always assess the bladder wall size and bladder wall thickness for you to be able to distinguish these three. The incidence of chromosomal abnormalities and genetic syndrome is not increased, and detailed ultrasound scan examination is required, and 4-weekly assessments, delivery standard, and postnatal intervention is normally indicated because these dilated hydroureters are predisposed to urinary tract infection, chronic urinary tract infection. It's more for recurrent urinary tract infection rather than chronic. In terms of recurrence, no increased risk of recurrence. To move quicker, this is amniotic fluid. How does it come about? The amniotic fluid, first and foremost, there is water that comes from the mother via the placenta that goes to the baby via the umbilical cord. The baby will absorb, will take this water into this bloodstream, and the water will be filtered by the baby's kidneys and will be peed as the baby's urine and form the amniotic fluid. How does the water move out of the amniotic sac? The baby has to swallow the water and breathe it. Both swallowing and breathing will lead to the water being absorbed by both the baby's GI system and the pulmonary system into its blood, and it will be brought back via the umbilical arteries back to the mother. So this is how it circulates. But early on in pregnancy, before 20 weeks, let me say there is a big contribution from exudation of the baby's skin. Some fluid just seeps through the baby's skin because the skin is so thin and porous. This fluid just seeps out. Some seeps through the chorionic plate here, the placenta. So this is how fluid moves, and this is how it circulates. So it's important to remember this as we discuss fluid. As a result, the fluid sort of follows the placenta function pattern. You know, the placenta reaches its maximum around 32 weeks in terms of its functional capacity. Then it begins to slowly die, right? To decay slowly, begins to reach its maturity and begins to die slowly. But for certain women, it happens fast, where they have some risk factors, high blood pressure, and many other things. So the amniotic fluid follows more or less the same pattern. You can see that it reaches its peak of almost 2,500 around 32 weeks. This is normal, right? Then it begins to fall. So towards term, it is normal for amniotic fluid to be less, because you can see that the lower central, which is the fifth central of the amniotic fluid, is quite low, really, at 44 weeks. So, oligohydramnios occurs in 1 in 100 pregnancies less than 24 weeks. We use the deepest pool, as you are aware, and when the deepest pool is less than 2, for those who decide to use a FI, if the FI is less than 5 centimeters, we call that oligohydramnios. We need to know that there are 3 major causes of oligohydramnios that we have to investigate for whenever we encounter oligohydramnios less than 24 weeks. One of them is urinary tract abnormalities. We have already described them. We have bilateral renal agenesis, multicystic or polycystic kidneys, and urethral obstruction. It could be due to urethral atresia, it could be due to posterior urethral valves, but the failure of the baby to pee will lead to oligohydramnios in early second trimester. Then the second cause is preterm pre-labor rupture of membranes. This is why it is important to take a history and to always do transvaginal assessment for women who come with oligohydramnios. Then the third reason is uterine placenta insufficiency, or what we call placenta insufficiency or dysfunction. Normally, with this condition, there is associated fetal growth restriction, and the Dopplers will be abnormal, including the uterine arteries and umbilical artery, and you may see redistribution in the MCI. So remember, oligohydramnios, we have to look for 3 main things. 1, is the urinary tract system normal? 2, is the woman not ruptured the hem membranes? 3, are the Dopplers okay and the baby growing well, so that we can pick up uterine placenta insufficiency? In our region here, we see these cases of uterine placenta insufficiency. So don't say, can we see it at 22 weeks? Yes, we see. Because of the hypertensive disease of pregnancy, which really afflicts some of our women. Investigations, detailed ultrasound examination in cases of unexplained oligohydramnios, amnio infusion may be useful to allow for a detailed examination of the fetus, and in some cases to even demonstrate rupture of membranes. Because if you put a fluid there and the membranes are going to pop out through the cervix, and you see. Then invasive testing in the current type should be done when they are associated defects. Then ultrasound scan every 1 to 3 weeks to monitor fetal condition and assess amniotic fluid volume. In case of membrane rupture, assessment of lung growth may be useful so that we can predict pulmonary hypoplasm. This is where we measure lung head ratio. We will do it when we do the abnormalities of the thorax, the lung head ratio, to try and prognosticate babies where we are expecting that they may be having pulmonary hypoplasm. Therapeutic amnio infusion is not useful, it doesn't work. We have had women who have asked us to say, Chiremba, is it possible for you to put back the fluid? Since you are telling me that the fluid is run out, can you please put it back? Please tell the woman that it doesn't work, because it will still come out. And the amount of fluid that really the baby produces and circulates per day is too much. The baby should be circulating close to 300 ml per hour, if my memory still serves me well, but I'll double check and update you with this information, which is a lot really in terms of exchanging of fluids per hour. So that if you are to replace it, then you have to do it probably twice a day or every day to keep up with what the baby needs. In utero placenta insufficiency, Assessment of fetal growth and Dopplers in the umbilical ductus and MCA will help to decide the best time of delivery. If the cause of fetal urinary tract abnormalities, standard obstetric care and delivery, and you follow the condition, we've already presented the condition. If it is a case of rupture of membranes, expected management vaginal delivery if cephalic presentation is recommended. Of course, it depends on other factors, obstetric factors. In case of placenta insufficiency, C-section of vaginal delivery, depending on gestational age and fetal size, and degree of fetal compromise, age defined by Doppler and CTG. Prognosis depends on gestational age and diagnosis, cause, and also gestational age and delivery. In oligodermis before 24 weeks, the prognosis is always poor. The reason why it is poor is because of the lungs. The issue of the canalicular stage, which will be interrupted and the lungs will not develop properly. In case of bilateral renagenesis, somatic or polycystic kidneys, these are lead abnormalities, and normally babies die in the neonatal period. Where premature rupture membranes happens at less than 20 weeks, and it is also with poor prognosis. And about 40% miscarry within 5 days of membrane rupture due to chorioamnitis. And in the remaining 60% of pregnancies, more than 50% neonates die due to pulmonary hypoplasia. Urethral placenta insufficiency resulting in oligodermis less than 24 weeks is very severe, and most likely outcomes is intrauterine fetal demise. Recurrence. For agenesis or multicystic is about 1 to 3%, and infant abolisis is about 25%. Protein rupture of membranes, which is occurs in about in 10 to 25% of the cases, it can recur, but can be reduced by severe cyclage and progesterone. So this is very important for women who rupture the membranes to remember that they have to be given progesterone and sometimes the cyclage. Then urethral placenta insufficiency, 10% is the recurrence risk, but it can be reduced by giving aspirin from 12 weeks. This is why we want women to come to us at 12 weeks so that they can benefit from aspirin. Always remember this. Polyhydramnios. I think I'm about to finish. So just give me 2 seconds to sip a glass of water. So the prevalence is 1 in 100, and which is fairly common, polyhydramnios. How do we diagnose it? Measurement of the deepest pool greater than 8 is our diagnostic level, and between 8 to 11 it is mild, between 12 to 15 it is moderate, and greater than 16 it is severe. In about 80% of cases, the polyhydramnios is mild, and in 15% moderate, and it is only 5% where it is severe. Most cases of mild polyhydramnios are idiopathic, but most cases with moderate and severe are due to maternal or fetal disorders. So with polyhydramnios, even if you don't see an obvious defect, and we have moderate or to severe polyhydramnios, assume that there's a defect you have missed, especially tracheoesophageal fistulas, because we cannot pick most of these ones in uterus. So always manage these cases as if there's an underlying swallowing problem. In most cases, polyhydramnios develops late in the second or in the third trimester of pregnancy. Acute polyhydramnios at 16 to 20 weeks is mainly seen in association with the twin-to-twin transfusion syndrome. I hope this will make you understand why when we see monochorionic diamnotic twins, why we ask them from 12 weeks, we want them to come at 16 weeks, so that we do not miss the evolution of this kind of acute presentation of the disease. So that is why for mono, they have to come back at 16 weeks. Why coronary diamond, they have to come back at 20 weeks? It is because we don't want to miss this acute presentation of TTTS. Associated abnormalities, they are essentially two major causes of polyhydramnios: reduced fetal swallowing and increased fetal urination. The reduced fetal swallowing due to brain abnormalities, e.g. anencephaly, dental walker malformation, fascial tumors, gastrointestinal obstruction, esophageal duodenal atresia, small bowel obstruction, compressive pulmonary disorders such as pleural effusion, diaphragmatic hernias, CPAM, and chaos. Complete airway obstruction syndrome, that's chaos, there's total obstruction of the lungs. Then CPAM is cystic pulmonary adenomatous malformation. Then narrow thorax cage due to skeletal dysplasia and fetal akinesia deformation sequence. These babies do not move. And conditions such as arthrogryposis, they are also part of that fetal akinesia deformation sequence. So these are neuromuscular impairment of fetal swallowing. This is why for those who have worked with us, you see us going through a protocol of checking all babies with polyhydramnios, because we'll be trying to exclude all those conditions we listed there that may impair swallowing. The second one is increased fetal urination, maternal diabetes mellitus, and maternal uremia. This is why we now have a policy in our protocol to say the moment you suspect that somebody is polyhydramnios or GTT, that is the reason why. So the moment you want to refer somebody to fetal defects because of polyhydramnios, order OGTT. Do not overlook that, so that they come with results to the clinic. Maternal uremia, increased glucose and urea cause osmotic diuresis. You do not routinely test for urea because it's not normal for women to just have uremia without glucosuria as well. So that may explain why we do not routinely test for uremia. Probably it's something we may think of to say, could we have a situation whereby the mother could be just uremic? But normally these are women who will be terribly sick. Because if you are uremic, you are going to have all these kind of breathing problems and so forth, the sweating, salt on your skin, and so forth. It will be from the clinical picture that the woman is sick. Then hyperdynamic fetal circulation due to fetal anemia. This is why assessment of the middle cerebral artery, PSV, is important, peak systolic velocity. We may see this in case of red blood cell isoimmunization or congenital infection. We may also see this in case of fetal and placental tumors, such as sacrocoliteratomas, placenta chorangiomas, and twin-to-twin transfusion syndrome. Detailed ultrasound is needed, invasive testing for karyotype if there are fetal abnormalities or growth restriction associated with polyhydramnios. Then DNA testing for myotonic dystrophy mutation if there is abnormal posture on the extremities. Then glucose tolerance test if there is associated macrosomia, and torch test if there are fetal features suggestive of infection. But in our case, glucose tolerance test is done for everyone. Please don't say there's no macrosomia. All polyhydramnios, we have to rule out diabetes. Then ultrasound scan everyone to 3 weeks to monitor fetal condition and amniotic fluid growth cervical length. Prenatal therapy. Maternal diabetes mellitus is the underlying cause. Good glycemic control will treat it. Eye drops due to dysarrhythmias antiarrhythmic medication will treat it. Eye drops due to fetal anemia, intrauterine blood transfusion, pulmonary cyst or pleural effusion, thoracoamniotic shunting will treat it. Twin-to-twin transfusion syndrome, laser occlusion of the placenta, anastomosis or amniotic drainage in our setup will treat it. Then fetal or placenta tumors, laser occlusion of feeding vessels will treat the polyhydramnios. Effects resulting in reduced fetal swallowing, severe idiopathic polyhydramnios, serial amniotic drainages if there is cervical shortening. However, the procedure may precipitate premature labor. It is true. What we have done, I think you agree with me that we've been doing amniotic drainages and we've not seen a lot of this complication because we have been bombarding the women with tocolytic medication whenever we do this procedure. So that's one of the interventions to suppress premature labor for amniotic drainages. An alternative and effective method of treatment is maternal administration of endomethacin. It also works if you want to keep things in control. We've administered to women with polyhydramnios where we do amniotic drainage and the fluid seems to want to come back. We put them on endomethacin. However, whenever we put them on endomethacin, we bring them back to measure the ductal arch diameter because it may cause ductus arteriosus constriction. So we monitor these babies with ductus arteriosus diameter and velocity assessment. So if you are not in a position to do fetal echocardiography, it is not advised to give endomethacin for this polyhydramnios case, but we give endomethacin because we can monitor the ductus arteriosus. So remember this, because sometimes you give it to an ancient and to cause problems. And said, Dr. Verenga said we can give it. So standard obstetric care delivery in most cases is recommended here. Fetal abnormalities, induction of labor at 38 weeks is recommended when in a hospital with intensive and care and pediatric surgery. Fetal tumors, consider cesarean section and exit procedure. Exit means you operate as soon as the baby comes out. Then severe polyhydramnios, controlled induction and membrane rupture at 38 weeks is recommended to avoid umbilical cord prolapse. Prognosis depends on gestation age, the cause of polyhydramnios, and also gestational age at delivery. Most of preterm labor is precipitated. Recurrence not increase, but however, if there is a material fetal condition, it depends on the cause. Right, so we are done. So we did urinary tract system and the amniotic fluid. So it's done. Next week, we'll move on to the next topic. I'm not sure which one, but I think we'll announce it next week. But we'll move on to the next topic we haven't covered. I'm done. Are there any burning questions? Because our time is up. If there are no burning questions, I want to end the meeting. If you are not in a position to ask questions, you can ask your questions in the group. The WhatsApp group, I think all of you are in that group. You can just ask the question there. But otherwise, enjoy your weekend and all the best.